Hello friends, in this video I'll be demonstrating you a case of high myopia in which I'll be doing direct horizontal chop. Uh, by this time already side port incisions are made. Because this was a high myopia case, then generally I like to make a posterior limbal side port incision because reaching to that depth is important and they are when as posterior incisions are helpful. I've stained the interior capsule and I'm washing the dye now. I'll refill it with visco through side port and that would prepare eye for the construction of the main wood. In all high myopia cases, we have to make sure that our incisions are made posteriorly because generally AC depth increases while we are doing any procedure, any maneuvers in these cases. And if we made anterior incision, then the reach to that place of action can become difficult at times. Now I've refilled the AC. Now it's time to go for capsulorhexis. Capsulorhexis in a high myopia case is an important and challenging at times because what happens that in high myopia cases it is difficult to size the rhexis. We tend to measure it by being away from iris from a certain distance from the iris, which is difficult to see in high myopia cases because the iris is generally pushed far into the sulcus and we are not able to size the rhexis properly. And if generally we tend to make larger rhexis in case of high myopia. So now you can see hydrodissection has been done and posterior wave was clearly evident. And this was a NS 2 to 3 case, very easily choppable. And again, you will see as I put my phaco probe inside, the lens iris diaphragm will go into retropulsion and that causes ciliary body stretch and it can cause pain to the patient. So what we can do in case patient complains of some kind of pain, we simply should lift the iris and that stops the stretch of ciliary body and patient is generally relieved and that also reduces the depth. Now you can see my phaco probe is almost vertical and it is reaching the pieces because this was a very high myopia case and the lens that I put in this case was around -6. The nucleus density was okay and anyway because the AC depth was good enough, so I was not much worried about the protecting endothelium because my plane of emulsification was very deep. I did many chops and I completed the nucleus management and now only cortical cleanup is left. So you can also appreciate the staining of anterior vitreous with trypan blue dye, which is the evidence of zonular weakness in this case as well, which was there, but it was a very small quadrant, so I did not put a CTR in this case. Anyway, in any case of high myopia, we can put CTR in the back to stretch it. What that stretching helps in, it helps in preventing the formation of PCO in case of high myopia. What happens that in high myopia case, the bag is usually very large and it crumples around the lens IOL and it causes a PCO formation in every case, and it also pulls the lens forward and that basically disturbs our prediction of effective lens position in a high myopia case. So generally at many places what is followed that if the IOL power is less than 15, then with every case we book a CTR along with our IOL and that keeps the PC stretched, prevents the formation of membranous PCO and it also keeps the IOL in effective lens position, and that's where is very helpful for getting a good refractive results in a high myopia case. Now I am closing my side port incision with stromal hydration. Generally what happens that it's not very difficult to close these high myopia cases because the AC tends to form really nicely. And we have to just make sure of one thing, that we should never use pylo in a high myopia case, because that can cause retinal detachment or even GRT in high myopia cases. And in case your AC is not forming, you can use air bubble to make it, but never use pylo. Thank you. In case you have any queries, please drop a comment. Thank you.